ഓക്കെ 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 എന്നാട്ടോ ഇത് നമുക്ക് നിർത്താം കേട്ടോ. ഓക്കെ ഓക്കെ ഓക്കെ. Hello, welcome again here to DiCarmel NCLEX review program. All right, okay, so we are having our fourth session on NCLEX review, our summer special. We're going to have this every Saturday going forward for the time being. All right, okay, so thanks everyone who is coming in for the session. All right, so in the last few sessions we had, I think we had a good time learning together. And we're going to make it better as the days progress. And thanks everyone for the trust you have put in DiCarmel all this time to achieve your NCLEX-RN dream. For those who have been struggling for some time, and you understand how effective our learning strategy is from the sessions we had in approaching the questions by thoroughly knowing the content wherever you need to. So remember what we learned. Passing NCLEX is a combination of the thorough content knowledge and also your critical thinking skills. So that's what we're going to develop here as the days progress. We're going to make it better every single day and learn together in the process. All right, so I believe everyone is just coming in. Okay, so I'm going to give a couple minutes for everyone to show up. It's Saturday morning. Everyone is in the resting phase. Switching to our weekend review preparation. All right, so yes, as I mentioned, as I had let you know, we are having the session every Saturday here in New York time, 9 a.m. to 10 a.m. And also you can access the program from wherever you are at your local time, which is mentioned right here on the screen. Okay, so just dedicate your time for this just 1 hour per week to improve your chance of passing NCLEX. All right, and we're having the session running on YouTube and Facebook. So thanks everyone joining the session from either side. You are welcome to bring up your questions, queries to make our learning together effective. All right, so let's start with some question answer review here. As usual we do. Okay, so I'm going to show the first question for the day here. And remember, even before we get into the questions, this is what we need to remember. We had to stop memorizing and start to understand the content as thoroughly as you can, which should make your NCLEX passing much more easier than that you think. Because remember what happened, sometimes we know all the content, but we fail to apply our knowledge in the appropriate way because our knowledge is just stuck in the knowledge part. But remember, as we have discussed before, knowledge go into the next level of learning into application analysis, and that's what gets tested in our NCLEX exam. So to see how it get applied, we're going to see some question here. I'm going to have the very first question displayed here on the screen. All right, so the first question, patients with which of this diagnosis need protective measures from infection? Okay, so let's take a few seconds to see what are the possibilities. And those who are joining from wherever you are, please type in your location as well, so we can know where we are interacting from. Wherever you are, please type in your location. All right, so thanks everyone. Thanks Maria. Thanks Neetu. All right, so let's see what could be the best response for this question we have here. Okay, so just let me know what your response is and we'll go from there. Okay, so patients with which of this diagnosis need protective measures from infection? Okay, so to answer this question, we need to understand what each of these terms means. What is polycythemia? What is agranulocytosis? What is erythrocytosis? And what is leukocytosis? Yes, and as I mentioned, being as thorough with the content as you can will help you to answer many questions effectively. Without that, your preparation would be simple memorization, which will not really help. Okay, I can see some responses coming through. I can see option D. Okay, option B. All right, so let's see what the reality here is. Okay, so before we proceed and see what our answer is, I'm going to show you some of the related information. Go from there. First of all, when we talk anytime when we have a question related to the blood cells, the background information we need to know there is this. Let's start from here. We know that our blood cells are RBCs, WBCs, and platelets. And it is so important for us to know what is the function of each of these. I'm sure most of you know RBCs help with the oxygen transport. WBCs, they are the fighters of infection, and the platelets help with the clotting, right? Achieving the clotting. Okay, I'm sure, again, most of you know that fact. And also, when it decreases, when any of these count decrease, that's where we use the suffix penia. And when it increases, that's when we use the term cytosis. And that's how it is in most of the cases. Once more, when it decreases, when any of these decrease, that become penia. When it increases, it becomes cytosis. But there is an exemption for the cytosis rule. I'm going to show you that on the next page. So as you would have noticed, an option called agranulocytosis. Agranulocytosis, the cytosis sounds like it's increased, but in fact, it's a decrease. But we'll see that specifically as we move forward. And then there are cases where all of these can decrease together, RBC, WBC, and platelet. That's what we call as pancytopenia. And which is a very simple but a classic information they test you on NCLEX. So pancytopenia, which is very common to happen in patients who may develop bone marrow depression from various conditions, various reasons. There are medications which can cause bone marrow depression. Some of the immunosuppressives, some of the chemo drugs can cause immunosuppression because of the bone marrow depression that can happen. So yes, bone marrow depression, when it happens, remember it is from bone marrow, all the blood cells are mainly getting formed. That's our RBCs, WBCs, and platelets. When all of them getting formed from the bone marrow, if there is destruction or damage to the bone marrow, all those three can decrease. That's what we call as pancytopenia. Okay, hope it's clear. And let's go to the next page. Okay, so and then we heard the term polycythemia. I'm going to go back to the question for one quick second. Yes, you can see once more the terms we have: polycythemia, agranulocytosis, erythrocytosis, and leukocytosis. All right, so first polycythemia. Okay, so what is polycythemia? So polycythemia is an increase in the RBC count, right? It's an increase in the RBC count. And when it happens, it's a response. In most of the cases, when it happens, is a response to chronic hypoxia. Wherever there is a chronic hypoxic situation, which can happen with sickle cell anemia, thalassemia, cyanotic heart defects, particularly tetralogy-FLO. We could talk about one of the coming sessions for sure. So tetralogy-FLO and then COPD. So these are some of the chronic hypoxic conditions. When body is going through a state of chronic hypoxia, that's where the body can start to produce increased RBCs as a compensatory mechanism. The same can happen during fetal life, because remember, within the fetus, the fetal lungs are not functional yet. The baby gets the ready-made oxygen from the mother. It is not sufficient or 100% as sufficient as we can generate ourselves. So they are in a mild state of hypoxia. So as a result, as a compensation, they also have increased RBC production. So basically, all these conditions can cause increased RBC production, and that's what we call as polycythemia. And it can also happen if we go and be on a high altitude for several days, body can produce extra RBCs. All right, so we understand what polycythemia is. Now, if you refer back to the question once more, now we know what exactly is polycythemia. That's increase in RBC count. And we already heard increase in any of this is cytosis, right? We heard erythrocytosis. Yeah, so that's also same as, so option A and C are exactly the same, which both means increase in the RBC count. So now we are down to option B and D. Okay, and what is option D? What is leukocytosis? Leukocytosis shows increase in WBC count. Now, the question, we know the function of a WBC is to prevent infection. And if someone has an ongoing infection, this WBC count increases. So that means the increased WBC count indicates an ongoing infection. So putting all this information together, what do we think our final best answer would be? So we heard A is out, C is out. And leukocytosis shows an ongoing infection. The question is asking which of these need additional protective measures to prevent infection. So the answer is option B, which is A, granulocytosis. Okay, and why? Again, we were talking, when you hear the suffix cytosis, that means increase. But this word agranulocytosis, that's an exemption for the rule. When you hear agranulocytosis, that shows a decrease. That shows a dangerous decrease in the WBC count. And this is what I'm talking here. So agranulocytosis is a super classic topic I talk often, which is reported by many students from the exam. So it's a dangerous decrease in the WBC count. And patient can present with many of these symptoms such as fever, sore throat, malaise. And these are patients who need a reverse isolation, again, because of the high risk of infection as we are talking. And also we need to have their blood count checked periodically to make sure it's not dropping. If it keeps dropping, that's a danger sign. They have a higher risk of infection. All right, hope is clear. And also, they test you on what are the common reasons for agranulocytosis, which include, these are the super classic medications that can cause agranulocytosis, as many of you may have heard from my sessions before. so which includes propyl thiouracil and methimazole. These are two classic anti-thyroid drugs. Okay, by the way, everyone know the drugs for hypothyroidism, which is levothyroxine or synthroid. But these two drugs in the list, these are anti-thyroid drugs, which are drugs we use for hyperthyroidism. So these two drugs can classically cause agranulocytosis. So patients on these drugs has to be monitored. And then carbamazepine, you might know that's an anticonvulsant, which can cause the problem as well. Also, a similar risk is there with antipsychotics, both standard and atypical. And very often you must see this with the atypical antipsychotics such as clozapine. So in fact, before a patient go on these drugs, they may have to have their blood count checked to make sure they are not at added risk. All right, so hope it's clear, and therefore putting all this information together once more, so we find our final best answer here is option B, because agranulocytosis is a dangerous drop in the WBC count, which can increase the patient's risk of infection. All right, so we are through our first question. Okay, so let's proceed into, yes, thanks everyone, joining the session through our Facebook and YouTube media. And please do share this with your friends and bring them in, because many need the surveys, right? So what you're getting, it also can be learned by many more. There are so many who are struggling with the NCLEX exam for sure, because they do not know what exactly is to be prepared, how to prepare, how to focus, what is important, what is not important. Yeah, many do not know that fact. That's where I'm here to help you to improve your content understanding. Remember, if you thoroughly understand the pathophysiology, you'll be able to apply the knowledge whatever is the way the questions comes. That's what we are trying to develop here, step by step through this, our weekend, our Saturday live session. Yeah, NCLEX Saturdays. Yes, so please come on in and please share this with your friends so that many more can come in. All right, so then let's go to the next question we have here. Okay, here we go. Let's take okay, looks like a little bit lengthy one, right? Okay, so please take few extra seconds to read, choose your answer, and send me your response, please. All right, so yes, I think we spent some time, and please send your response, whatever you have at this time. Okay, so let's talk about it. I'm still waiting for more responses. Okay, so let's talk about this question here. All right, so Alex and Rachel, who are both carriers of sickle cell trait, have one child who has sickle cell disease. They are concerned all their future children will have the disease. Which is the best explanation that can be given to Alex and Rachel? All right, and the options, the first one, prophylactic treatment during pregnancy will prevent disease in the future pregnancies. Option B, your future children will have 25% risk of having the disorder. Option C, your experience from taking care of one baby with sickle cell disease will greatly improve your adaptation in case your future babies will have the disease. And finally, your future sons will have the disease and your daughters will be carriers. Okay. All right, so let's talk about it. And by the way, in our very last session, we had a question related to genetic disorders, and we are talking particularly about hemophilia. If anyone hasn't heard that, please refer back to that video as well. You will find that in our YouTube library, as well as you will find that on DiCarmel Facebook page. Okay, so again, to answer this question, what we need to do, first we need to have the thorough understanding of what kind of a disorder is sickle cell disease or sickle cell trait. So sickle cell, it is categorized as an autosomal recessive disorder. So that's what we need to know. And also to understand what genetic disorders in general, we need to start probably from the chromosome. I think we had the same image being discussed in the last day, but in case if anyone didn't hear, just to have a quick preview. As you can see, we have 23 pairs of chromosomes. Out of 23, 22 pairs are called autosomes. And one last pair is a sex chromosome, which is XX and XY. Yeah, so that's our sex chromosomes. And any disorder that is inherited through the sex chromosome, that's what we call a sex-linked or X-linked. Again, the very classic one, hemophilia A and B. But we were talking, no, we didn't hear, maybe. So there's a third type of hemophilia, which is hemophilia C. So that one can happen in boys and girls. So that's not sex-linked, okay. And so that one, along with many other conditions, are coming under the autosomal disorders. And to make it more specific, this is how the disorders are categorized. You can see it's categorized into three: autosomal dominant, which we rarely see in NCLEX questions, conditions such as Marfan syndrome or similar conditions. Again, less the chance you might come across that in questions. But then autosomal recessive, there are several conditions which are listed under autosomal and also sex-linked, which we discussed already in our last session. So autosomal recessive, what exactly is autosomal recessive disorders are? Let's find some related facts right here on our next page. Okay, here we go. So autosomal recessive means if both parents are heterozygous for the trait, the chance to have the disease, the chance to be a carrier, to be chance to be free from the disease is 25 to 50 to 25. So these are the classic conditions which come under the list that include cystic fibrosis, PKU, that's phenylketonuria, sickle cell anemia, hemophilia C, thalassemia. And okay, so condition we have here is sickle cell. So we can see that's also an autosomal recessive disease. And what exactly it means, I'm going to make it simple for you to understand. So suppose this is the chromosome pattern. Okay, let it be a certain pair of chromosome of the father, and let it be the chromosome pattern of the mother. I mean, it doesn't matter father or mother when it comes into autosomal disorders, because it can be carried through any of them. But we're talking, if it is sex-linked, it is always through the X chromosome. When it comes to autosomal, the sex doesn't matter, father doesn't matter. But imagine they both parents are carriers of an autosomal recessive disorder, such as being displayed here. So when you see, this is what we call as heterozygous pattern. You can see one has that abnormal gene, that's what you see, and then the other one doesn't have that. So yeah, one of them have, the other one is free. So this is what we call as heterozygous pattern. And they could be carriers of an autosomal recessive disorder. So they don't have the disease, they could be just carriers. Now, when there is fertilization, there are four possibilities how these chromosomes can mix up. So, for example, these two can mix up to, the first two come together to make that into a homozygous pattern. You can see both the abnormal chromosomes come together here, so that will make it a homozygous pattern. And then the other possibilities could be just like their parents. One of them have it, and the other could be free. And then, so the same, yeah, so these two can be together. Yeah, so they both have, the second and the third one have the parent just like their parents. And then finally, a possibility they both would be free. So you can see there are 4 possibilities when they have children. So the first possibility, you can, sorry about that, okay, erase, okay. Just go back real quick. So this is what I meant. Okay. All right, the possibilities we talk, yes, so these can come together, so making it a homozygous pattern. And then the next one, so it can be just like their parents. And the next one also just like their parents. And finally, a child who is totally free from those abnormal genes. So here, when you consider when these 2 abnormal genes come together on these 2 chromosomes, they can have the disease. And whereas the next 2 possibilities, 2 of these possibilities are carriers just like their parents. And finally, the last option is they are totally free from the disease. So here, if you look, you can see out of the 4 possibilities, there is 25% possibility the child will be affected with the homozygous genes. And the next possibility is just like their parents, they are carriers. And the last option, they are totally free from the disease. And what we discuss is exactly what you see right here, what we call as 25% to get the disease, 50% to be carriers, and 25% to be free from the disease. So that is 25, 50, 25. So putting them together and looking back into the question, you can see what would be the answer. So the answer is going to be option B. Your future children will have 25% risk of having the disorder. And by the way, everyone know option A and C are just distractors. A genetic disorder is not really preventable, right? I'm sure we know that. It's not something preventable. And option C, that's not the answer, ideal answer to the question. And if anyone thought about option D, your future sons, okay, so we talk about sons and daughters when it comes into sex-linked disorders, so such as in hemophilia. Remember, we were talking again the last session when the mother is a carrier, the son become affected, and vice versa. Or when the father is affected, the daughter become carrier, and so on. So the son to daughter categorization apply when it's a sex-linked disorder. And I hope it's clear. So therefore, in this given situation, our final answer is going to be option B. Your future children will have 25% risk of having the disorder. Okay, so let's go to the next question here. Here we go. Okay, so thanks everyone joining through our different medias from different parts of the world. All right, hope you're having a good learning session here. And again, please share the link with your friends on your portals. So bring in your friends, whomever is seeking for assistance to pass the exam as well. All right, so let's see what we have here. Cohorting is acceptable for which of this group of patients? Option 1, a patient 1-day status post cholecystectomy for cholecystitis and patient receiving chemo. Option B, a patient with a 3-day history of diarrhea and a patient with HIV. Option C, a patient with the rule-out bacterial meningitis and a patient with bacterial meningitis. And option D, a patient with pancreatitis and a patient with colostomy. And by the way, when you read this question, okay, so let me have your responses, please, those who have seen it. All right, so thanks everyone coming in for the session. Please send your responses. Okay, so I can see different responses. I can see your selections. I can see option D. I can see B. Okay, so and I can see option C. By the way, when you answer NCLEX question, every single word should be analyzed and understood. So if you do not know that, make sure you use your practice sessions to get to know the terms, like standardized terms that you might come across in NCLEX questions. So, for example, if someone is confused what rule out means pending diagnosis. It's a patient who is pending for confirmation of bacterial meningitis and a patient with the bacterial meningitis. And also, I believe all of you know status post. Yes, after something, right? After a certain occurrence. Okay, so based on what we are understanding now, let's see how we can answer. Now, what exactly is cohorting means? If that's a term which you do not hear all the time, a simple definition of patient cohorting. Basically, it's the placement of patients exposed to or infected with the same laboratory confirmed pathogen. I mean, if two patients have the same condition, then they can share the room together. So that's the criteria we talk when we talk about patient cohorting. All right, now let's go into some other principles we had. By the way, if you are a new NCLEX taker, okay, you could be taking your exam for US, Canada, or Australia. So wherever you write, the exam remains the same. And they do test you heavily on infection control. Remember, NCLEX is focusing on nurses' responsibility as a patient educator, right? We are the one who are interacting mostly with the patients. We have such a major role in educating the patient and preventing infection. So infection control forms a significant part of NCLEX questions. And so therefore, keep that information in mind, and also the principles of prioritization and the principles how you can apply the infection control through various principles. And that's what we're going to see right here on the screen. All right, thanks everyone again joining the session from different parts. Anyone coming in new, appreciate. All right, thank you. Let's see some principles we can use for patient room sharing. Here we go. So this is the infection control patient room sharing strategy you can consider. One, clean patient should only be placed with a clean patient. Patients with the same diagnosis can be put together. Okay, so we heard that's what is cohorting, right? Patients with the same diagnosis can be put together. That's what cohorting is. The next point, a positive patient should not be put with a patient with any infection. That's what we heard in the first statement, right? Yeah, pretty much the same. And the next one, a patient with a confirmed disease should not be placed. Remember, we're talking the rule out. Yeah, here we go. Someone with a confirmed disease should not be placed with someone suspected. Because remember, the one who is suspected can become negative once the test results come. And we don't want to expose that person to someone who's already confirmed and making that person also susceptible. So that's why a patient with a confirmed disease should not be placed with someone who's suspected. I think this is highly relevant in this time of COVID. I'm sure probably now things are getting in a little bit more control, but consider the time, it's still difficult in some parts, as we are aware, that is true. But overall, when it was first started, the situation, we didn't have sufficient beds and we were putting everyone together, someone coming with a suspicion, now going with a confirmed patient. So they're infecting, cross-infecting, and then spreading it like anything, as we understood, right? So that's exactly we're talking here. So someone suspected should never be placed with someone who is confirmed for any communicable disease. And finally, an immunosuppressed patient should never be placed with an infected patient. Okay, so these are the criteria we have to keep in mind. And with that information, let's go back and look into the question once more. So let's see how we can eliminate or choose our answer here. So once more, if anyone didn't see the question before, yeah, cohering is acceptable for which of this group of patients? Option A, patient 1 day status post cholecystectomy for cholecystitis and a patient receiving chemo. The moment you hear chemo or radiation, think about possible bone marrow depression. Remember, we were talking about bone marrow depression at the beginning of this session. When there is bone marrow depression, there is a possibility of pancytopenia. The count, the WBC count, the neutrophil count can drop. So that's where there is very high risk of infection. So we never place someone with a suspected infection with someone who is immunosuppressed from possible bone marrow depression and pancytopenia. And so leave that option there. And then option B, a patient with a 3-day history of diarrhea and a patient with HIV. Okay, so 3-day diarrhea, I mean, we know the reason? No, we don't know. Some diarrhea, we still probably don't have a clear picture. So it could be gastroenteritis, could be likely an infectious process, and a patient with HIV. And we know an HIV patient is highly susceptible for all sort of infection. They can get all opportunistic infection, right, based on whatever they're exposed to. So we don't want to place this immunosuppressed patient with someone with an infection. So that's the problem with option B. So we heard option A and B are not going to be a good possibility. So what about option C? A patient with a rule out bacterial meningitis. Okay, I think we already heard this. If someone has a rule out status and someone has a confirmed status, they should never be shared together because they can infect. I mean, the confirmed person can put the suspected person also confirm and making the disease to spread. So that's not a good option either. So what are we left here? So, I mean, we cannot go with option A, B, or C. So the only option we are left here is option D, a patient with the pancreatitis and a patient with the colostomy. I mean, now question, why? So remember, don't just take it because someone is explaining. Always try to know why and how. So that's the key of passing NCLEX, achieving your NCLEX dreams. You should try to understand every single question, wordings, and the explanation with a thorough understanding. And you should be able to explain possibly. So even if it's presented in a different way, you'll still be able to identify an answer. So option D is going to be the answer, as I told you. Patient with the pancreatitis and a patient with the colostomy can be together. And the question, why? So this is a reason. There are several different conditions which are not contagious due to various reasons. So these are some of those conditions you can identify, which I have listed right here. So these are conditions that are not contagious. And I would say pretty much all of these are repeated one from the test. So which include eczema, atopic dermatitis, that could be another name for eczema, psoriasis, okay, also colitis, another one, Crohn's. Okay, so all these conditions which are listed, let me clarify something here. Okay, so with confusion, here we go. All right, so all these conditions, okay, out of this, let me see this one, quick second. Okay, so out of this whole list, all these conditions are autoimmune disorders. And whenever you hear autoimmune, remember there is no causative. It's an immune system issue and there is no causative involved. So without a causative, a disease cannot transmit. Okay, so we understand why these conditions will not spread from one person to another. And now PCP, okay, so if you have heard PCP, it's a classic kind of pneumonia affecting AIDS patients. Well, okay, now when you hear the moment AIDS, well, we think, oh, it's highly contagious. No, that's not the point. So remember, AIDS is not contagious in itself, unless there is a mode of transmission of the organism from one person to another through blood or sexual routes, as we are aware. But what is the problem with HIV/AIDS is these patients will have ongoing immunosuppression that will put them in extreme immunosuppression and risk of other infection. That's the problem these patients have. So because of that risk, this is kind of a pneumonia these patients can get. So again, this is a specific type of pneumonia affecting HIV/AIDS patients. Almost 80% of them, as the condition progresses, can get HIV, can get PCP pneumonia in this AIDS patients. So, but if someone has a healthy immune system, for example, suppose we are a nurse caring for a nurse with a healthy immune system caring for an AIDS patient, we are not necessarily at any risk of this particular pneumonia. And also pancreatitis is one among them, because a lot of times how pancreatitis happen, it happen as a non-infectious process. And let's see what we have briefly about pancreatitis. It's a sterile inflammation and it's called an auto-digestion of pancreas. Remember, the pancreas produces various enzymes, right? It produces all the enzymes to break down the nutrients, the carbohydrate, fat, and protein. I mean, it produces the lipase, amylase, and trypsinogen, right? It produces all those enzymes which help to break down the nutrients. But when those nutrients, I mean, normally how it works, it'll get released into the duodenum, right? As you can see, get released into the duodenum, it starts to work within the duodenum. But due to some obstruction or due to some other inflammatory process, it starts to digest, it starts to work within the pancreas. It can digest the pancreas itself, and that's what we call as auto digestion of pancreas, so which is very often related to alcohol, gallstones, or biliary stones, etc., biliary tract disease, etc. So this is the reason again why pancreatitis is not an infectious condition in most cases. So I hope it is clear, and now we clearly understood why exactly. And also, this is what I was telling, for any disease conditions to spread, this is what we need to understand. There should be three components involved. There should be a susceptible host, there should be pathogen, and there should be a favorable environment. So when these three come together, that's where the disease happens. And I hope it makes sense. And this is also what we call as the disease triangle, if anyone hasn't heard. So without having one of these components in there, a disease cannot transmit. Again, the moment you hear a disease, whether it's contagious, ask yourself, is there a pathogen involved? Is there a microorganism? Without that, a disease cannot spread. It is as simple as that. And I hope it's clear. And then let's go to the next question here. All right, so here we go. So we already saw that. Okay, so we know the final answer is a patient with pancreatitis and patient with the colostomy. Yes, we already saw the answer. Here we go. Our next question. All right, so if everyone can send your responses, please, based on your best understanding at this time, before we go into the explanation why and how. Okay, so a patient who is on neutropenic precautions secondary to treatment of multiple myeloma would be taken care with which of the following measures? All right, so okay, I can see different responses. I can see A, B, All right, and we are just left with another 15 minutes, but if you can bring in your friends, I'll appreciate to make use of the session for many more. Yeah, thanks everyone joining the session. You can see Ruth, Nidhu, Femina, Nato, Lily, Teji, Maria. Okay, also I have few people on YouTube. All right, so let's talk about the response we have here. Okay, so all right, so a patient who is on neutropenic percussion secondary to treatment of multiple myeloma would be taken care with which of the following measures? All right, personal option A, I can see the response is mostly between A and B. Now let's see the truth. Okay, so first of all, what made you eliminate option C? And I'm sure we know that we are talking about neutrophils. Neutrophils are WBCs. We were talking earlier, the role of WBC is to prevent infection, right? Okay. So yeah, the role of WBC is to prevent infection, and it has nothing to do with the bleeding. So for anyone who has a basic understanding, and if anyone was watching right from the beginning, so that's not anything to do with the bleeding. Option C, we can eliminate. And option D, okay, protein and iron, they might be required for healthy immune system, blood cell production. That itself is not going to make the answer here, right? So we are going to be between A and B. Okay, so now in order to answer this, before we go into further discussion of this question, let's try to understand briefly what multiple myeloma is. Let's start from what multiple myeloma is. We already have seen this information, right? Nothing new. All of you, most of you had seen this before. We have the three types of blood cells, RBC, WBC, platelets, and their functions we understood. RBC, yes, we know transport oxygen. WBC is to prevent infection. Platelets to control bleeding. When they all decrease, that's penia. When they increase, cytosis. And whenever they decrease, that's pancytopenia. We already heard those information. And also we are talking an assumption. What was that? Agranulocytosis. Yeah, that's a dangerous drop in WBC as we learn. All right, so let's continue here. Okay, so here we go. All right, so in order to answer this question, this is another thing we need to know. Okay, so this is another thing we need to know. What absolute neutrophil count is. So what is absolute neutrophil count? It's the number of neutrophils among the total number of WBCs. So what is, everyone might know as healthcare workers, nurses, right? Yeah, everyone, nurses getting ready for NCLEX exam, you would know the average WBC count is around 4 to 10,000 or 4 to 11, whatever, based on wherever you look, or based on the different labs where it's being done. And within those 4 to 10, this is the average count of the neutrophils, 2,200 to 7,700. And if that count is above 2,000, we are in a safe zone, or our risk of infection is minimal. That's risk category 0. And if it goes in between 1,500 to 2,000, that risk is risk category 1, and 1,000 to 1,500 is risk category 2. If it goes further down, if it goes below 500, that's what we call as neutropenia with the risk category 4. So we can assume the patients with the ANC below 500 extremely high risk of infection. That's the first term we need to understand with the neutropenia, which is possible to happen in these patients with the multiple myeloma as well. Now, let's try to understand briefly what multiple myeloma is. So multiple myeloma, you might have heard, is a cancer condition kind of similar to leukemia, we can say. So this may originate from, just like a blood cancer may originate from bone marrow or within the lymphoid tissue, this particularly originate from the bone marrow as well, and is particularly involving the plasma cells. What you can see right here, some of the description. So it's a cancer condition affecting plasma cells in bone marrow, causing development of multiple tumors composed of abnormal plasma cells. So plasma cells are nothing but immature B lymphocytes. I mean, we know those are the cells which has a role in immunity. It leads to bone demineralization, resulting in osteoporosis and pathologic fractures. Yes, again, it may start from one location, then it spreads throughout the body, resulting in severe osteoporosis and pathologic fractures, which is very classic of multiple myeloma. They can end up with the multiple fractures, what we call pathologic fractures. And also, this can cause bone marrow congestion and pancytopenia. Again, going back to the term we're talking, there can be a drop in all the count, including RBC, WBC, and platelet. And if you know that information, so again, this is what the plasma cells. So these are the cells which produce a lot of antibodies, again, which has a significant role in the immunity we have. And so putting all this information together, if you go back and see, we already heard option C and D are out. So it's between A and B. Option A, personal protective equipment when entering patient's room. Option B, avoid any possible unsterile items in patient's room. Now remember, we are talking about a patient who is neutropenic, extremely high risk of infection. So we definitely need a personal protective equipment. That is right. I don't disagree with that. But at the same time, someone with extreme immunosuppression, we need to keep a sterile environment. So that means our answer is going to be option B, because we need to avoid possible unsterile items. I mean, have you heard for a patient on neutropenic precaution, we should not bring in anything fresh, like a fresh fruits or flowers or a flower bouquet. We shouldn't bring in, or we shouldn't have like a plant in the a natural plant in the room. So these all could be source of infection for this patient. So we have to keep everything sterile as much as possible. So, and if you talk about for this in caring for a child, probably we need to bring in even sterile toys. We cannot keep anything unsterile there. So that's where option B becomes the best answer. But some of you may still have questions. Why not A? I thought that's right. That's what you think, right? So remember, we talk when a patient, what is the purpose of PPE? PPE basically, I mean, definitely we don't want to infect someone. But if we are infected, we're not going to go care for a patient, right? We're not going to do that. So instead, the primary purpose of PPE is to protect us, right? Protect the healthcare workers from the patient. So here, the question is, when patient has the immunosuppression, how do we protect them? That's what the question. The question is not asking how do you protect yourself? No, the question is asking how the patient can be protected, because the patient is extremely immunosuppressed because of the neutropenia. So therefore, again, the best answer here is option B. I hope it's clear, everyone. And if you have any unresolved questions, you're welcome to share your concerns, and we can talk about it. I can get you more information as time allows. So probably we'll have time for one last question before we end today's session. And we'll meet back in a week again. All right, so here we go. The last question for the time. All right, so thanks everyone for joining this session, and yeah, I can see the face, the YouTube learners here. Yeah, Jomia, Stanley, Ajo. All right, so yeah, we'll have more questions coming up, and make sure you subscribe the channel if you haven't done it, and also don't forget to share and like. So that's how your friends will also be able to know this free session we are having in your preparation. Okay, so let's see what we have, and also please send your responses at this time. Okay, so which of the following is true regarding immunosuppressive therapy in post-kidney transplant patients? So the options we have, option A decreases the risk of infection in post-transplant patients. Option B decreases cell-mediated response by recipients. Option C decreases risk of opportunistic infection. Option D decrease the need for dialysis in the immediate post-op days. So what is the truth? So everyone please send your responses at this time. Okay, I can see options. I can see option D. I can see option B. All right, so let us see what the truth is. Okay, so it's between B and D. Okay, so close enough. Okay, so now when we this is how we, as we're talking, we need to understand the content so well that whatever way the questions come, you'll still be able to answer to the point that you can pass NCLEX. That's our goal, and for that purpose, we need to be as thorough with a deep understanding of the content. So this is a routine practice, a routine intervention we see in every single transplant patient. These patients will be on lifelong immunosuppressives. And the goal is to prevent the organ getting rejected out, right? So without that, remember, anything that doesn't belong to us get rejected out because of our natural immune response. So that's the underlying reason why these patients have to be on an immunosuppressive drug. But then also understand, if a patient is on an immunosuppressive drug, will the risk of infection decrease? No, they have higher risk of infection, right? Yeah, when you hear immunosuppressive, automatically you understand the risk of infection is high, not less. And option B, decrease the cell-mediated response by recipients. Okay, so what does that mean? I mean, there are different types of immune response we have. You may have heard, like there are two types. Basically, there is a humoral immunity. I'll show the information on the next page in a second. There is humoral immunity, and then there is also cell-mediated immunity. Humoral, that's what we get through the antibodies. And then there is cell-mediated immunity. So there are two types of immunity which are involved. So just leave the information there for a second, and I'll come back into it. Then option C, decrease the risk of opportunistic infection. So we are talking, these are drugs that can cause immunosuppression. Something which causes immunosuppression, will it decrease the risk of opportunistic infection? No, it will increase. So option C is going to be increase, not decrease. So that's why these patients can get candidiasis, fungal infection in the mouth, etc. And option D, decrease the need for dialysis immediate post-transplant days. No, this is again a routine practice in every single patient undergoing dialysis. Until the transplanted kidney starts to work, they have to continue on dialysis because the patient need to have the hemodynamic status maintained. If not, the body won't be able to function and the kidney won't be able to get accepted. So that is not a reason either. So basically, our answer here is going to be option B, decrease the cell-mediated response by recipients. And just to make it a little bit more clear, based on what I was telling, this is some of the related facts I want to explain. So these are the long list of medications these patients can be on. Yes, again, we'll have sessions on this in the coming weekends as well. So cyclosporin, azathioprine, tacrolimus, and I can see it's a everlasting list. You can see. Is it? Do you have to memorize this whole list? No. But what you need to know, you need to understand, these are medications these patients are on, and the patients need this to prevent the organ getting rejected. And also understand at least one thing, if you know about this drugs, this is going to cause significant immunosuppression in these patients with a very high risk of infection, or these are kind of patients who need the said to be reverse isolation. And also, as I was telling, there are two types of immunity. This is what we call a cellular and humoral. Cellular, that's mediated by T cells. Remember, there are two types of WBs. There is B cells and the T cells. The lymphocytes, B and T lymphocytes. So this is mediated by the T lymphocytes that's there for months to years. So this is what involved or what caused the transplant organ rejection, delayed hypersensitivity, etc. Whereas humoral immunity, it is caused by the B lymphocytes, which is acting through the antibodies. Its action is only for days. So that's what helps for bacterial destruction or anaphylaxis or allergic response, etc. Okay, so I hope it's clear now why our answer is clearly and specifically option B. Yeah, so these drugs will reduce the cell-mediated immune response. Again, I told you, this is the immunity which caused the organ to get rejected. So until death, patients will have to be on this drug. Otherwise, the body's immune system will reject the organ out, and patient will have to go back to dialysis then. So I hope we had this session helpful to learn together many things, and we're going to end the session here as the time has run out. And thanks everyone for joining the session. And as I always remind you, don't forget we had to start to understand the content, right? So don't try to memorize the content. Try to know the content as thoroughly as you can. So that way you'll be able to reproduce the facts whichever way the questions come. So that's what we're trying to achieve through our pathophysiology applied NCLEX preparation. So thanks once more for this session, and we'll meet back in a week.